So, okay, week 6, and we're going to be doing the recording. I actually did forget to tell you all the assignments for this week. Remember, we did the quiz 4. You guys did great. There's that CJ Sims, and there's that NCLEX questions. Make sure, if you can, attend a review. I want you to know Dr. Brown monitors reviews, and those students borderline who have went to reviews, sometimes she gives a little more grace. Not that she's inconsistent, but she might listen to some perhaps what happened, why you couldn't do something, and maybe allow you to do it. Okay. I'm just letting you know that she is workable if you show the effort. So going to reviews benefits you, number one, because you're going to hear it right on top, but it also can benefit you also, in the end when you really need that. So as I said, hematological and immunological dysfunction. So how do we measure hematological dysfunction? Well, you talk about hematological, it's all about the blood. Well, we measure blood by the complete blood count. We're going to look at hemoglobin, hematocrit. We can see infections by white blood cells, platelets, part of the coagulopathy system, and we're going to be going into that too. Now, one of the most common of all of the dysfunctions in the blood is iron deficient anemia, right? Many children come in and they're like, well, my kid's just not as active as they were. They're pale. And we know that as kids get older, they become more picky on what they want to eat. So they're not going to be eating like the green leafy vegetables like they should be eating for iron, right? So if we're seeing that they're not eating good, we got this fatigue, or we're seeing they're getting sick all the time, or any inference of any bleeding, we know a CBC is the first thing we're going to do. So as I said, the anemia, iron deficient anemia, number one of all of the anemias is iron deficient anemia. And there's other anemias. We're going to go into them. Well, think about what anemia means. Anemia means the blood cells, the red blood cells in the body are decreased, hemoglobin, hematocrit. What does hemoglobin do? It carries food and oxygen to the cells. If you don't have a good enough number, is the cells getting the food and oxygen they need? As simple as that, okay? So people with low hemoglobin hematocrits don't have as much energy as those that have higher ones, because people with higher ones have that high energy, that stamina, because they have oxygen and food going to the cells. Now, in children, they're basically saying it's less than 10. Um, so that is, in adults, you might see it a little bit lower, they'll go, but usually about 10 is we'll do a cutoff. Now, here's the types of anemias we have. This means lack of red blood cells, hemoglobin, hematocrit. They don't have enough. Why does that happen? Well, iron deficient anemia, we've already said that. That's nutrition. But there's other nutritional things out there. We have the folate, B12, and then any sort of chronic blood loss. Maybe you have your period 3 times a month, 2 times a month, right? That can happen in the adolescence, where they're going through this hormonal changes and they're having just, all of this bleeding, and they have to go to adolescent medicine to find out what's going on. So that's part of it. Now, decreased blood cell production can occur in something called the bone marrow failure. Means the bone marrow's not giving us not enough of the red blood cells, the hemoglobin that we need. Now, this can occur, and the number one thing of that is aplastic anemia. That's the hemoglobin, hematocrit, and your red blood cells. You're not getting enough, and they just don't make it. So you could see that it's almost like a leukemia if you think about it. Your blood cells are producing, but not enough. So these children probably are going to need your blood transfusions, periodically. Now, increased red blood cell loss. Well, again, that could be just, bleeding. Now, we're going to go into some bleeding coagulopathies. We're going to go into hemophilia, ITP, and I'm just going to mention DIC. I don't want you to go crazy on it, most senior nurses have a hard time understanding what happens with DIC and the treatment of it. And it's something that I'm just going to mention. Now, increased red blood cell destruction. So your body's producing it like crazy, but these cells are bursting inside your body. And we know that the increased blood cell production, destruction happens in sickle cell. And we know if there's two people, a mom and dad, with a trait, the child has a 25% chance, right? That's part of the sickle cell disease. Now, one of the ones that you've heard about but don't understand is called thalassemia. It is extremely similar to sickle cell, but far worse. This is a lifelong treatment of blood transfusions because what happens in thalassemia is they are like rectangular shaped cells that burst quick. And what's inside the red blood cells? We have iron, which is your food, and you have oxygen. That iron bursting in the blood can become toxic, even if it's from our own cells. So this patient, this child, is going to be getting something to get rid of all that iron in their body. It could be medications, or it could be something called apheresis. It's similar to dialysis, but it just removes cells that you don't want in the body. Thalassemia is usually Mediterranean. And then we have this G6PD thing. I've seen one of them in my whole lifetime. And it has to do with sugar and hemolysis. And these children, you have to be careful of the type of even antipyretics, Tylenol, Motrin you give. You can't give it with sugar because it's going to cause red blood cell hemolysis and they blow up and explode basically. Okay, I've seen one and the mother explained it to me because I had never seen it. And in nursing, you're going to see stuff like that. You can't know everything about everything, but you can ask questions, right? And then we're going to see the increased blood cell destruction through things like drugs, toxic substances, and children getting infections. Their red blood cells are eaten up. It's just part of the pathophysiology of children. So, anemia. What are you going to see? So, you get this kid, he's pale, decreased energy. Take a stethoscope and listen to the heart. And you're going to hear you should hear a chikum, chikum, chikum. That's the normal blood going through, and that's the heartbeat. But because there's not a lot of fullness of that blood vessel and the cells are banging around, you hear a lot of turbulence. Okay, so with that increased turbulence, you're going to hear that murmur, like swooshing thing that you're going to hear. And then the heart says, all right, let me beat faster. Let me get this blood around because the body needs its food and needs its oxygen. And with that, they're going to go into failure if you let it sit at a hemoglobin that's too low. If you're too anemic, you can't sit there because your heart's going to try to take over. It's what it does. And then because your body's not getting all the nutrition, iron, oxygen it needs, you'll see the cyanosis and you're going to see growth retardation because you don't get food. Just like feeding food in the mouth to an infant, they're not going to grow while the body needs its oxygen and its iron as we get older also to grow. So, how do we diagnose this? Well, as I said, number one, it's that history. The kid's tired, the kid's pale, the physical, right? And then the CBC. Now, we can go ahead and treat the anemia all we like, but what is the anemia due to? So, what is that underlying cause? I see a lot physicians treating what they see, and then, especially in an emergency situation, they can't go and look at what caused it. They can maybe do a stool for occult blood, seeing maybe it's a GI bleed, but that's something that has to be followed up at another time. So sometimes the family or the parents don't follow it up. It's that underlying reason, what happening, because many of these are treatable. Iron deficient anemia, you take iron or you change your diet. That's as simple as it goes. Supportive care for anemia, well, you get a kid in with a low hemoglobin, you are going to give fluid to make that vascular space fuller. But remember, now, this is a concept of med-surg too. If you take a low hemoglobin and you give a bolus of fluid to it, okay, you're stretching that blood out further, that hemoglobin is going to go even lower. Just remember that. So usually it's that first CBC we take before we give fluids that we're measuring the anemia by, okay? And then there's another thing they say is oxygen therapy. Well, again, this is controversial. If you don't have cells to carry the blood oxygen around, if you give extra oxygen, is it going to make it any better?
No.
That's the controversy. May not, right?
Uh,
But we do know that bed rest does help. Decrease the expenditure of energy, and that can help with anemia until we can get the hemoglobin on hematocrit where it should be. So assessing it, how old is a kid and what's their racial ethnic background? African Americans, we know it's sickle cell, so we can look for that. We know Mediterranean background, that's your thalassemia. So that sometimes can clue us in. And then getting that history, when did this happen? Did it happen, for a couple of years? Is this just recent? Has there been, any trauma going on? And of course, always, always rule out that stool for occult blood because GI bleed is the easiest thing to rule out. Now, children don't like pinches. They don't like needles. They're usually pretty afraid of them. So again, prepare them for it. And Nicholas Children is great. They use numbing stuff for everything. And one of the things they use for even just sticking just a straight stick, they do something called J-tip. And this little syringe, TB syringe, and it has this little power pack, as I call it, on it. And you click it together and it goes psh, and it forces lidocaine into the tissue where the needle's going to go in. So they feel the touch, but they don't feel the sharpness of the needle. And I always make a game of it with the kids. I bet you're going to jump when I do this. They go, no, I'm not. And they jump and I go, ha ha ha, you jumped. And it now becomes fun and the kid's not afraid. And that's my goal for future visits for us. Again, everything we do for this kid, we want to decrease tissue oxygen needs. We don't want them screaming and yelling and going bonkers. We want them to keep calm because there are no reserves on many of these kids. I've seen kids with 5 and 6 hemoglobins, and that's quite low. So iron deficient anemia, we know the most common of all, can start from birth. So they used to, and I've watched, I said, I've been a nurse forever. Let's just say forever, 50 years, I don't know, long time. And I know that they've gone from giving formula with iron or formula without. And what they finally figured out, and it makes sense to me, is that they're giving iron fortified formula or breast milk. And we know with breast milk, they're going to be given vitamin D. It also happens to help, with this anemia type of thing. Now, as we start feeding them foods, we give them iron fortified cereals at 6 months. And we start with rice cereal because we want to get that iron in. Not every kid's going to look at a plate of broccoli and go, oh, yum, 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 I want it. Now, my grandson's the crazy one. He would think that's the most amazing thing in the world and eat that whole plate up because he loves broccoli. But not every kid's like that. And we know that. So, introducing diet is not always what's going to be good for children. Not everybody's going to want it. So at that point, we are going to be needing to do some iron supplementation. And there's all sorts of oral ones. And we do, of course, have the IM dextran if we need to get to that point. So as I said, sickle cell is an autosomal recessive disorder. African American, Native Africans are your carriers. If you have two parents with a trait, 25% of the children born will have sickle cell. Now, let me explain sickle cell easily to you. Sickle cell has a shaped cell like a C, like a sickle. And the body has all these vessels and they bifurcate and get smaller. And what happens sometimes, I see it a lot in the knees, I see it in the arms, hands, feet. Those are your tiny vessels. Those little sickle cells get stuck on a bifurcation and it covers up the vessel. And then all the other cells come behind it and it gets swollen and swollen. And down below, it's not getting oxygen. it's not getting what it needs. So it becomes, pale. That area becomes swollen and painful because it's not getting the blood flow down to where it needs. So, what do we do first to get that blood flow moving the best? Now, of course, we're going to treat the pain. Pain is huge, but that's not your priority. Let's dilate the vessel with a lot of IV fluids, bolus it, get those vessels huge, and then all of a sudden, the cause, that clog up, is going to have, oh, I got space now, and the cells start going, and the blood goes, and then the pain will decrease. So, your priority is an IV bolus. Now, doesn't mean I don't have morphine or something in my other hand. I'm going to give it at the same time, but your priority is, and this is a question you see NCLEX, you see HESI. This is part of, if you ever take care of kids, give them an IV bolus. That's number one. Let's pop open those veins and get her going. Because if not, it's going to be pain, cell death, and et cetera. And we don't want that. Sickle cell hurts. Now, one of the things with sickle cell, part of why they don't have these cells going through the vessels is usually due to hydration. Hydration is big, or trauma. Now, if you have a fever, you have all this insensible water loss, right? So it's going to happen to the vessels. They're going to shrink. So children with sickle cell are told have a bottle of something next to you all the time. If they're playing sports, and they should be playing sports, make sure that they have water, fluid, something. Keep those vessels open and wide because it's usually after being outside, running around, sweating, that these kids could go into sickle crisis. It also happens if there's some trauma there and swelling could cause it. And of course, as I said, that fever, infection can cause it also. We don't think about it, but also stress. Yes, Adiel.
How inclined would we be to encourage participation in contact sports in a patient with sickle cell, considering that they can have an enlarged spleen?
Well, it depends on what level of sickle cell they are. That's a great question. Um, there's always a choice of what sport to be involved in, and all of the risks need to be told to that parent. But if they have an enlarged spleen, just like with mononucleosis, you're not going to have them out there playing sports. You're going to protect those bellies, and maybe this kid's going to be swimming or bowling or something else, even tennis, whatever. Still out running around being a kid, but in a different way. Okay. All right, so first thing we do with sickle cell, as I said, this is a type of cell that goes away quick. They're always bursting, they have short life. So it is not uncommon to get a sickle cell kid in to the ER in crisis, low grade fever, 100.8, nothing crazy, but their hemoglobin and hematocrit, I've seen 5 and 15, 6 and 18, 7 and 21 is a great hemoglobin and hematocrit. So you know that these children are going to come in and they're going to get blood products because we need to get that oxygen back to that child. That's always that you see with these children coming in. Rarely do you see a good hemoglobin hematocrit on a sickle cell child. So you're going to have them minimize their energy loss, right? They're anemic, sickle cell anemia. They're going to be not have all that energy. Again, number one, hydration, hydration, hydration. Then we're going to make sure that they're medicated for pain. And we tend to be afraid to medicate younger children with morphine. And morphine is one of the safest of all the opioids to give. It's been around forever. It's been here longer than me. So it's so well known. We know how to use it well. They also have problems with electrolytes. Make sure that when we are, getting those labs as we're starting that IV, that we do check the electrolytes, make sure their potassium is where it should be, right? And if any infection, we need to start IV antibiotics pretty quickly. Now, most of these kids are on one penicillin pill a day. It's like a prophylactic. And they start that at a young age and up. And why the young age? They're immunosuppressed. They have no antibodies when they're younger, right? These children, normal children are born and they don't have an immune system. So sickle cell, they're immunosuppressed. They've got, no fighting them. So to prevent crisis, to prevent fever infection, they're on these prophylactic antibiotics. We do watch the retic counts. And as I said, blood transfusions are given because we know that there's no oxygen going around and we need to feed those organs. We need to give that oxygen there. And again, do we put oxygen on these children? Does it work? Do we have cells? It's always one of those things that I'm like, well, all right, I'll put it on, but it doesn't necessarily mean extra oxygen's going. Now, there is no cure at all for this. I've seen some older children get bone marrow transplants. I've seen them work, and then I've seen most don't. So that's one of those do I or don't I? I think if you're always in crisis, it's something that I think a parent would try. Prevention of sickling episodes, keeping hydration, keeping them from being sick. Those are the two big things. And as I said, I mean, with COVID, I mean, poor kids with sickle cell, going to school and then being exposed, early when they brought them back to school very early, they're at more risk for these infections. So usually what happens, and the leading cause of death is infections on these children because they can't fight it. You can live a long life with sickle cell. So, what do we need to know about sickle cell? Well, we need to know early intervention. We need, as soon as this child feels something, get this kid into medical care, call the doctors. They have a little fever, get the antibiotics, get them, fluids before they have the sickle crisis, right? Giving that penicillin as that prophylactic. And then you can stroke in the eyes, in the brain, anywhere. So you have a kid with sickle cell who has a headache, take it seriously. It could be a sickle crisis in the head. You see sickle crisis in the chest, you see it in the head, and they're more dangerous, okay? In the hands, the feet, the knees, those, all right, it's blood flow. We could take care of it, but it could be there, or it could be even in the lungs. It sort of mimics almost like a blood clot to the lungs. Again, treat these kids like normal kids, let them be kids. And I think that's the most important thing in any of these conditions. And it's always the prevention. Okay, so we have sickle cells. Now we have thalassemia. Cooley's anemia is the big name for it. These are like rectangular, as I call them, cells. And it is a shortened life. And as I said, they burst. What's in red cells? Iron and oxygen. So you don't have oxygen and the iron is spewing around in your blood, and that iron can really cause a lot of damage to you. You usually see this in descendants of people from the Mediterranean Sea. Why is that? I'm not sure, but I know that it's been proven over and over again. Now, there's all these types. You don't have to go into every type. You don't have to learn them all. You just need to know that usually when we talk thalassemia, usually questions regarding thalassemia are the one that's the major, which is Cooley's anemia. This is the one that these children need transfusions to survive. Now, how often are these transfusions? Well, it depends how quickly their hemoglobins drop. Once a week, twice a week, once a month. It all depends. And in children are all different. There is no child that's the same as another child. They're always respond differently. And that's why I love kids. So at birth, you don't see this. So later on, you're going to see where these children have a lower than normal hemoglobin hematocrit. We know that children at birth don't start making their own blood cells till about 6 months old, 5 months old, in that area. And up to that point, it's mom's hemoglobin that has been carrying them along. If we're starting to see that the hemoglobin hematocrit's going too low too quick, usually you'll see these kids, severe anemia. They're not growing the way they should. They're not getting iron. They're not getting oxygen. They're going to see a kid's too small. They're going to be looking. And on that CBC, they're going to see those RBC shapes. They're not the way that they should be. And at that point, we know that we need to watch them closely. These children still, they're going to need blood transfusion to maintain the oxygen and iron in their body, normal hemoglobin levels, And because of all this iron spewing in their body, they're going to get these iron chelating drugs called desferal. And that helps combine with the iron and you excrete it through your urine. And that works for a while. Usually, as younger children, it will work, but as it goes on, they probably need to be hooked up to this apheresis machine. At Nicholas Children in the PDICU, nurses run that machine. They're taught it's like an ECMO machine. It's like the apheresis machine. I was lucky enough to work with them, and you can pull off whatever component that you want off of them. I always like to do all the fancy stuff. I wanted to figure it out and understand it so I could take care of my kids. That was just me. So, how do we care for thalassemia? Well, these children must have their transfusions. You have to monitor their iron levels and chelation therapy, whether it is through the medication or through the apheresis, whatever it is. These kids are in and out. These really hard to be a normal kid with thalassemia, okay? And if we are giving blood transfusions once a week, let's say, to these kids for life, they're going to have some sort of complication with it. And that's one of the big things we work at. They're going to get all these weird antibodies in their blood, and it's as it prolongs, it could become more and more difficult to get blood for these kids. They can live a long life, but common causes. Well, think about anemia and what happens. You have a big hemoglobin hematocrit because we just transfuse you. Then all these cells die and it becomes low. What does the heart do? Beats quicker, faster. It wants to work hard. It wants to get oxygen around. So you're overtaxing the heart. Then you give hemoglobin hematocrit, you give blood transfusion, and the heart can relax. You are up and down and up and down. This heart will go into failure. That's my point there. It will go into failure. Sometimes they're going to remove the spleen to stop them from producing any cells at all, instead of spewing iron and the cells of iron and the cells, just exploding in their intravascular. They get rid of it, but sometimes they go into sepsis post-op, and it could go into organ failure, etc. Again, bone marrow transplantation is a cure. They're saying it could be. Again, it's not proven completely. So aplastic anemia. Now, when we talk about it, it's profound anemia, leukopenia, thrombocytopenia. Well, what does that mean? Hemoglobin, hematocrit, white cells, and platelets are all low. All of those are low. And that's usually what we see with aplastic anemia. So all components of the blood that you really look at are really low. So one of the things that we do with this is we treat it almost like it is a leukemia. We'll do immunosuppressive therapies to stop these cells, to try to help these cells perform the way they should. Again, bone marrow's tried to it. And it is a long haul unless we do the bone marrow and it works. So these are another type of sick kids. Defects in hemostasis means hemostasis. You start to bleed and you can't stop the bleeding. What do you think of number one? Hemophilia, right? Factor 8, factor 9, and it's also von Willebrand, and I love that word, von Willebrand. We'll go into it. This is X-linked recessive, so mommy carries this, okay? Now, sometimes these kids initially, we don't know that they're hemophiliac, and all of a sudden we'll see the extra bleeding and then we'll go looking for it. There are many different components that stop bleeding. Platelets stop bleeding. That's one of them. But you also have factor 8, factor 9, and this other one that this physician, this researcher called von Willebrand determined, and that's another factor. I've seen more von Willebrands than any other hemophilia. And sometimes they're mild. So they're not requiring, the factors like other. Now, what do you see with hemophilia? Well, these are the kids that fall down outside and they have their knee was hit on a rock and it's all bruised and it's becoming swollen and swollen and swollen. Overtly prolonged bleeding inside these joints. sacs. And that is something that can cause joint destruction and can later on in life cause a child with hemophilia to become into a wheelchair if we don't take care of these joints. So, what do we do with these children? Well, once we determine that they have some sort of bleeding coagulopathy, well, we're going to draw bloods. And what blood levels do we look at? APTT, PT, and we're going to look at other things called parathyroid and fibrinogen. Use those a lot when you're working with those ECMO machines and bleeding coagulopathies. We don't hear them mostly on, a doctor's office, ER, urgent care, but you'll see PT, PTT, platelet count. And those are things that you're going to look at and go, oh, this kid has to be, some sort of bleeding problem with it. So what do we do? Now I'm going to tell you a story on a 9-year-old kid. Came in with his dad with hemophilia, and he was one that was factor 8. And they'd been dealing with this a long time. It was a weekend because I worked weekends. I was one of those last Baylor shifts where Saturday, Sundays, which is great shift. And he came in on Saturday because he couldn't get hold of his hematologist. And he had fallen and he had a bruise and he didn't know if he should take his factor or not. So he came in and our doctor said, yes, he can have it. Well, the father asked me, I was orienting a brand new nurse into nursing, into the ER. And the father said, do you mind if I give it? I'm like, sure, child, absolutely. Well, my responsibility as a nurse to make sure he did it right. So I have to watch. Oh my God, he did it better than most nurses. He washed his hands. He laid the equipment out. He mixed up the factor 8 because it's a powder and a liquid. He mixed it together, filled up a syringe, went over to the child, used only a butterfly, that little metal thing that you use for blood draws. And the child and him picked out the vein. He stuck it in the vein. The kid held the butterfly. He slowly inserted it in, took it out, put a band aid on. And even my orientee was like, oh my God, I could never do that. I said, let me tell you, his way, what he did, most nurses don't do it with the aseptic technique and the manner he did it. And the way that they worked together was amazing. Why would I want to stop that? Say, no, I got to give it because I'm the nurse. It doesn't make me better. The point of the story is always let your parents help, but watch. Sometimes you'll learn something about it too. Now, usually it's clotting factors we have to use to stop factor 8, factor 9, von Willebrand. Sometimes, though, as I said, some of them are milder, and sometimes we could use a nasal spray. It's desmopressin, DDAVP. It's used also for diabetes insipidus, which decreases urine, but also it helps with hemophilia. So it's something that could be used. And then there's aminocaproic acid, and it's another thing that's also the children will be taking. Now, how do you manage a kid who falls down? How do you manage a kid 2 years old, just diagnosed hemophilia, sent home? Now, you can't tell a 2-year-old to sit still and not move, right? You better be patting the sides of your table if they're sharp, coffee tables, anything sharp sticking out in your house. It better be moved because you have to get that environment safe for the child. And that was a question I saw in a essay. And it's so true. You really have to make sure that the environment is safe. So prevent the bleeding is number one. But once we see it, it's just like an orthopedic injury. You're going to first rest. You're going to ice it, compress it, and elevate it, just like if it was a sprain. Okay. And we're going to give that home therapy of factor, whatever it is. These children can live a normal life. And as I said, as soon as they have these bleeding and their elbows, their joints, their ankles, wherever, give the factor because we want to prevent that joint damage. We don't want them to be in a wheelchair later on because blood is really caustic to those joints and it will cause damage. And then they're not going to be able to walk. I mean, there is some gene therapy that's going on, but it's not completely ready yet. All right, another bleeding coagulopathy. It's also called ITP, or idiopathic thrombocytopenia purpura. Now say that 3 times quick. Idiopathic thrombocytopenia purpura, ITP. P equals platelets. Platelets are low. Platelets low causes bleeding, right? Why does this happen? Well, in children, it could be acute or it could be chronic. And the acute stage would be following some sort of viral upper respiratory, some sort of infection. Usually, within a month or so earlier, they were sick. Well, kids are always sick. So it could be that. And you're going to see these kids, and I've seen quite a few. They come in, it could be nosebleeds that causes you to go and look. They had a nosebleed at the pediatrician. They come into the urgent care ER, and this is the third nosebleed in a month. That makes you do bleeding coagulopathies and a CBC, always a CBC. So you will see these kids come in nosebleeds, number one, or the kid comes in with all of these bruising, these little petechial rash on their legs or arm, and mom says, "This kid plays video games, never goes out. I don't know why he's doing that. He hasn't been in a fight. Why is he bleeding like that?" Well, again, we're going to do CBC and we'll see the platelet counts are low. That's usually the signs and symptoms there. So, how do we treat this? Well, they're already over the viral infection. So, we'll give IVIG, IV immune globulins, and anti D is another thing that we'll do. Now, if this kid is admitted into the hospital, there's some things that you need to be watching out for, right? With pneumonia, you listen to lungs, give antibiotics, vital signs. Well, in ITP, we're going to be avoiding sticking that patient with excessive venipunctures for lab works or IVs or anything, right? Because once you stick it, they're going to continue to bleed. There's no platelets, all right? You're going to be watching gums, urine, stool, looking for any ecchymotic areas on this child everywhere. And most likely you'll be doing CBCs to see is the therapy working and seeing if those platelet counts are coming up. And then sometimes we'll put them on corticosteroids. So it is watching for bleeding. And those are the things that you will do for ITP. You don't transfuse platelets usually, unless they're low. You can. Usually we want the body to try to make it themselves. Epistaxis, how do we treat it? Well, many of them like to put your head back and pinch it. And what happens is the blood goes down your throat, you gag, you choke, you puke, and you create more bleeding. So you don't do it. There is an NCLEX question on this. If you haven't had it yet, you probably will. Thumb, forefinger, hold it and bend them forward. Okay? Hold it for 10 minutes. If it still remains bleeding, you need to go get help. Because usually a normal kid will stop bleeding within that. Another thing you don't think about, what do kids do when they see blood? They flip out. Oh my God, I'm going to bleed to death. I'm going to die, right? Calm them down. Heart rate goes down, blood pressure goes down, bleeding will decrease. You see why I'm saying we do that? All right, immune, HIV, AIDS. Well, HIV, AIDS is something where we see many newborns born to mothers of HIV or AIDS positive. Their mothers are HIV, AIDS positive. And we know that the mother can give the child this, infection. So there's been a lot of stuff. Now, HIV AIDS came out in the 80s. So there's been a lot of research done on this already. And they've started this heart therapy. And they tried to start it when mom's 22 weeks pregnant and immediately after work. We're going to start with the antivirals also. And the reason that we give this at that time is we want that newborn to get the best immune system from the mom that we can, because she's taken the therapy, it's going to the baby. And once that baby's born, that baby's going to get antiviral. Do you know children born with HIV can seroconvert and become negative by 1-year-old. I think that is amazing. I've also seen triplets born. I don't know if they're still at Patches, but one has HIV, one has AIDS, and one has nothing. They might be older now that they're not there anymore. But can you imagine triplets, all different? So as I'm saying, all kids react differently. But the goal is just to improve that newborn's immune function. And that's the biggest thing with HIV/AIDS is whatever we're doing, we want to give that kid a chance. Now, pneumocystic pneumonia, PCP pneumonia, is that respiratory, most common that children do get. And we'll see that at that 3 to 6 months. And why is it 3 to 6 months? Remember, that's when mom's immune system is going away. So now it's the baby fighting for itself. So that's when we usually see it. So know that that's the one that we will see the most at that age in these children. So these these immune disorders, and how do we treat them? Well, blood transfusions, packed cells, whole blood, platelets, FFP. There's all different types of blood products we give, and all for different reasons, okay? Always watch out for transfusion reactions. And I'll warn you to follow your hospital guidelines. If you follow the guidelines by the hospital, whatever their policy and procedure are, you're doing things right. The one that I know forever, Nicholas, was you take vital signs, you hang up the blood. Of course, it's 2 nurses' signature. They have, all that stuff. Hang it up. 15 minutes later, another set of vitals, and then every hour thereafter, checking on it. If there's a reaction, what do? Turn it off. Yeah, all gone. See ya. And then again, take all of that stuff, put it in a bag, send it to the blood bank so they can find out, was it something in the blood? As I said, apheresis, very similar to your dialysis, but what it does, it separate components and it's going to remove whatever they want, whether it's getting platelets from a healthy donor or maybe removing platelets for somebody or another thing in there like the iron that they don't need. Another thing we might do is a bone marrow aspiration. Now, usually kids are sedated for this, but they're still going to feel a little bit, even with this sedation given. Be honest, especially if a kid has a long-term hematological issue. Be honest that you're going to have a little pain, but I'm going to do everything I can. So it's going to be as little as possible. All right. Again, getting them prepared. Don't lie. Kids don't like you to lie. That's when they get more fear. So when both parents have sickle cell, what's the chance of their child going to get it? Just a trait.
25?
It is 25. Yep. All right, we're going to go into some cancers. We know there's leukemias, there's lymphomas. We're going to start out with leukemia. There's 2 types of leukemia: acute lymphocytic leukemia and acute myeloid leukemia. ALL, AML. ALL is easier to treat. AML is more difficult to treat, just to let you know. I've seen them, kids 2 years old, come into the ER, have an infection, pale, look terrible, take a blood specimen, a CBC again, and we're seeing no white counts at all, no white cells, 0.1 WBCs, and you'll see all of the types of symptoms. I had a next door neighbor where I used to live, was always in and out of my house. Of course, kids were always at my house. Was 13, I think, which is actually old for this, but she went into the ER because she was tired. She had bruising, she had a fever, felt terrible, and had pain in her knee. And with all those symptoms, they did a CBC, and her initial white cell was 0.1. And she went through all of the chemo and did all those things. Today, She's a PhD from the University of Miami in psychology. So all of that treatment did nothing. She still had a chance, thank God, today, right? So, leukemia, what is it? Unrestricted proliferation of immature white blood cells into the blood forming tissues, which means your body's making all of these white blood cells, but they're worthless. They do nothing. They're going to have nothing to do with infection. Look at that. No white cells. You don't have anything that's going to fight infection for you. So these kids, talk about immunosuppressed kids you need to protect from you. These are these children. The liver, the spleen are severely affected. And, these kids act a lot, whether it's a solid tumor or in the blood. So, what do we look at? Well, number one, it's going to be that CBC. And they're going to ask for a smear. And they look at the type of cells and they're going to see, and you can see the bottom pictures there, what it should look like and what it's not. And again, you're going to see the levels. White cells should be 5, 6, 7, 9. I mean, those are normal. Too high, infection. Too low, less than 1. These are your leukemia patients. We also are going to do a lumbar puncture. We want to see if it's anywhere in there. It's part of the treatment for it. And again, bone marrow is going to be done. Again, let them know it's going to hurt. So you get a kid diagnosed. We've done all of the testing, and we're going to be starting chemo. This is where they're going to put a port in, so they're not going to always be pinched with IVs all over the place. And the first 4 to 6 weeks are your most intense and your most important. That's called the induction therapy. In 4 to 6 weeks, they wipe out all the cells, all the cancers, gone. But there could be stragglers in there. So then we'll put it in the central nervous system, and then we're going to do what we call consolidation therapy and maintenance to get any little piece of anything that might be left there. But your most important, induction. It's a goal of remission. Kids are sick during this time. Kids need to be protected. We're wiping out their entire immune system with this. Now, sometimes you're going to need a stem cell transplant for these kids. You need to wipe out what they have and then give them, somebody else's. Now, there's 2 types. One is autologous. Automatically, mine is the best. Autologous, automatically, mine is the best. If I have something saved like umbilical blood cord, automatically, I want that one because it's automatically better than all of them. Auto. Now you understand what auto means. Allogenic is a donor. Of the donors, you don't have to have a match. It's not like a blood type in this thing, okay? But your siblings are your best allogenic to have, okay? Now, just like if you had a transplant of a liver or a kidney or a heart, there's always going to be rejection. It is called graft versus host, but it's in your blood. It's everywhere. I've seen things like their faces feel like they're burning off. One older girl said that her face felt like it was burning off of her, and that was her graft versus host. All different things. So with these kids, it's going to be a long-term treatment, and it's going to be intense initial treatment. So make sure that the child and the family are aware, so they know how to treat their brother or their sister, their child, their daughter, their son. They're going to be in pain. There's going to be something somewhere, a bone pain somewhere. They will. Make sure we address that. And then, of course, prevent complications, as in wear a mask, wear gloves, hand wash, do all those things, and be even more aggressive about it than normal. They don't have white cells. There's no infection fighting, nothing on these kids. Also, because of all of the medicines, their hemoglobin and hematocrits are going to be low because you don't just kill white cells. You're going to kill all the cells, right? So hemoglobin and hematocrit are going to be low. These kids are going to get transfusions also. So it's part of the anemia, hemorrhage, be careful. And do you know that children oncology nurses are sought after? This is the one where if you're young and you want to travel, they pay like $25,000 sign on bonuses for 2 years of your service. It is a hard area to work, but it is very lucrative if that's something that you would want to do. And I'm going to tell you something about cancer and children dying. It is not that a kid died on you. How did you treat that child and those parents when they were alive? And that's what they'll remember because you can't save everybody. You think it's easier with older people dying? I don't. I think it's just as hard, older or younger. But what did you give them? How did you treat them? And they'll remember that. Okay. Prognosis for leukemia depends on what was the white count. Was it 100 white cells, 1,000 white cells, 2,000 white cells? Makes a difference. How old were they? Was it ALL or AML? Boy or girl? And the karyotype. Are they A positive or a rare blood type? So when they're looking for blood products, do they have to really look? Or is it always readily available? Makes a difference. And some more cancer stuff. So, talk about cancer and treatment. There's surgery, there's chemo, there's radiation. And all of these things, they're all used in combination for the best outcomes. So, what do you see in cancer? Very similar, just leukemia. Pain, fever, ecchymosis, petechiae, bleeding, lethargy, weight loss, all of these things can be part of it. Sometimes you have outward appearances, sometimes you don't. Now, one of the things dealing with these children in cancer and chemo and children that with fevers, um, neutrophil counts. Neutrophil counts, is part of the body, that helps with in fighting infection, right? Now, does anybody know what a normal neutrophil count should be? 2,000? Something like that? 1,000, 2,000? It's up in the thousands somewhere, right? Now, let's say you get a group of patients and let's say they're all just done chemo, and one of them's having a low grade fever and has a neutrophil count of 500. That's the one I'm going to be worried about. That kid's going to go into septic shock like that. So monitoring neutrophil counts are very, very important. If they have no neutrophil counts, they have no immune system, there's nothing to fight. So we are going to, and especially if they have a fever, we're going to check the source, whether it's sputum, whether it's the chest, whether it's blood, urine, everything. We're going to be checking for that, and we're going to be starting antibiotics. Yes, Adiel.
Is it common to see high-grade fevers in patients that have low WBC counts?
Oh, yeah, you can. And it could be just like 100.8. Doesn't have to be 104. Those high fevers are more viral than anything. But these are usually that low grade 100.8, don't feel good, and your neutrophil counts are low. Those are the ones that could go into septic shock doesn't need a high fever for septic shock. It's the body just can't fight it. And that infection just takes over. And then that's your kid who's going to end up intubated, go into septic, shock, blood pressure up, down, heart rate up, and you're going to be putting on vasopressors. This kid's going to be sick. So, as a nurse, we want to prevent it. So, always knowing your patient, and the group of patients, and knowing which one's going to require you first. And one of the things that we look for is neutrophil counts. And we know that with chemo, we're going to be knocking out all of those white cells, neutrophils, right? So those are the children with the lowest ones we're going to be looking at. I'm going to be monitoring. And again, making sure that we're doing everything we should do. Hemorrhage is something that can happen. We know as part of the treatment, we know that they don't just in cancer, whatever we do doesn't just affect white blood cells if it's chemo, leukemia. It could be red blood cells. So monitoring these children, their blood cells, their hemoglobin, hematocrit, giving them platelets or bloods, whatever they need to try to keep their values up is what we want. These children, because of spleen injuries, et cetera, IDL, this is the one you got to be careful with activities, because they can go, their spleen is overworking, trying really hard. And we know these kids are going to, during the beginning of chemo and that induction time, they are really going to be low hemoglobin hematocrits because it's not just killing those white cells, right? Or the cancer, it's going to kill the red blood cells also. So again, make sure that we give them frequent rest periods. Nausea and vomiting. We think of chemo, we think of vomiting, right? You say, oh, most patients are going to go through that. Well, when I started nursing, they used to have to wait till the child or the adult vomited before you could give an antiemetic. How ridiculous is that? Well, today we've realized let's do it before because we know it's going to happen. So make sure that these kids do get their Zofran or whatever. A lot of kids today are doing these synthetic cannabinoids. I've watched documentaries on it, and I think used correctly in conjunction with medical treatment, it could be used very well. And if it makes the kid able to eat during these times, keeping nutrition, how important is that? So, something that some parents have looked into. We know that they're not eating right. Make sure when we feed them, high protein, high calorie, full fat, give them as much in one bite that you possibly can, right? If they're young infants, increase the calorie count in their formulas. Or breast milk, there's ways you can increase calories. There's breast milk fortifier. Put it in there. Let those kids get all that nutrition they need. And how do we monitor nutrition? Height and weight. Daily height and weight. That is going for any treatment that's kids. That's why every time a kid goes to a doctor, an ER, urgent care, you get a height and weight. And you're like, why do we do it? Well, we're making sure, are they growing the way they should? And if not, it's telling you something's going on. We know mouth to anus, it can get or irritated. So make sure that we do things to prevent that. The food should be more bland, not spicy. Toothbrushes, be careful. Sometimes sitz baths, that nice warm on the buttocks where it's irritated can help because mouth to anus can be all irritated. And remember, um, neurological things can happen. Low white counts, low hemoglobin, hematocrit, low platelets can cause increased chance of bleeding. Now, we're giving opioids, aren't we? These kids are in pain. They're going to be constipated. You don't want this kid bearing down. They could stroke because of low platelets. It's one thing we don't think about, okay? Stool softeners. They're not going to want to eat extra, roughage in their diet. We need to feed them what they want to eat in the highest calories and fat and protein we can. But we need to give them something so that they're stooling and it's easy. If they're in bed, physical therapy, whether it's passive, we do it for them. Make sure that we keep their body moving. And again, give those analgesics as we need. Sometimes they have hemorrhagic cystitis. Again, trying to get fluid in them and give them frequent small sips of their favorite whatever it may be. Maybe we don't believe in that, juice or soda, but the kid's going to drink it. They need the fluid, right? And then we also think of chemotherapy. We think of no hair, alopecia. I've seen many fathers and brothers shave their head. I used to bring in little spools of ribbon and I would put bows in their hair and I'd have the same bows in my hair and we would be matchy match for the day. And that would take that child's thought away from the hair not being there, but the cute bow she had there. And these are things as nurses, you're going to create your own way to get that kid feeling good. Steroids are used a lot. And these Cushing syndromes that you see, the big, ruddy, fat cheeks, and all puffy in the chest and abdomen and their face, these can happen with children. And young children do get self-conscious about feeling fat and full. Make sure that you give them the exercise of your gowns if you have to put them on, or encourage the mother to get it size bigger jammies, to bring in for them. It does help with mental, even young kids. My 6-year-old grandson is like into what he wears. He has to be a cool dude, or he's not going to wear it, and it has to match. So that's at 6. So a lot of these kids are that area. So make sure we do that. Again, make sure that we prepare these kids. Use as much topical anesthetics as that facility lets you to use, whether it's for IVs, venipunctures, whether even spinal taps. We'll put a big glob of EMLA, which is a cream that numbs it. We don't want them to hurt. Again, pain management. Remember, it's just not the medicine. It's all those distraction things I've talked about. It's pad, it's TV, it's, video games, it's music. I go in and I start dancing in the room. The kid tries to dance with me. Say, what's this crazy woman in here dancing? So they think it's sort of funny. Oh, you laugh at me, I don't care. And we sit there and dance. And the mother said, well, how did you do that? I'm like, well, I was just trying to have fun. And I think your child liked it. And then they do it. So what are we doing? That repositioning, the hot, the cold, head elevated. And Tylenol and Motrin do work. So make sure that we have got a good schedule for it. There's 2 types of lymphoma, and you're going to see this. And I'm telling you, 50% of you will get it wrong. So I'm going to challenge you. There's Hodgkin's and non-Hodgkin's lymphoma, and there's a difference between both of them. Hodgkin's is lymph nodes, usually from the shoulders up. And you're going to see these big, big, big lymph nodes. Hodgkin's lymphoma, big, big lymph nodes. It's very evident, okay? They don't hurt. They're just big. But it starts to, close up, so they start with that cough. And then they might get the fever, the anorexia, etc. But what they'll do is they'll take a biopsy. It's right there. You can see it. There, get a little biopsy, and we'll see the presence of Sternberg Reed cells. And then we know at that point we need to treat them with chemo, maybe radiation of that area. Remember, with radiation, any of those little blue, purple spots, whatever the color is, do not remove them, because they take a lot of time marking it to get the area where they're going to zap that radiation, okay? And one of the things with Hodgkin's lymphoma is the risk for infertility, because you're given chemo, you're given radiation, and it could cause, a boy or a girl not to be able to have children longer, in long term. Now, non-Hodgkin's, you're not going to see lymph nodes like that. It's diffuse. It's all over the body, not just neck up. That's the difference, okay? So if you have a diffuse lymphoma, what is it? It's non-Hodgkin's. If you see painless cervical nodes, lymph nodes that are enlarged, that's Hodgkin's. All right. Treatment, just about the same. Again, we're going to be doing bone marrows. We're going to do chemo. If there's an area, usually it's so diffuse, it's not that radiation, it's just more like chemo. And of course, we're going to be checking the blood for that bone marrow. Again, chemo, and again, induction, right? Our goal is remission after that. And again, all of those things that happen with chemo, the nausea, the hair loss, etc., we're going to be concerned about it. Now, tumors, solid tumors, brain tumors are the most common solid tumor in children. And there's all types of what they are. Some are really nasty cancers, and some are benign, but they're occupying a space in the brain that it shouldn't. So it's pressing on something, controlling something in our body. And that's usually the way we figure it out. What we usually see in these children, especially with brain tumors, is you're going to see them vomiting. That gets worse over time as that tumor grows, right? and headaches that get worse over time because the tumor is occupying more space. It's not has nothing to do with vomiting. It has nothing to do with eating. It just has to do anytime. So it's worse symptoms as it goes. So what do we do for this brain tumor? Well, we like to shrink it through radiation. It does help. You have to remove less tissue of the brain, and we do chemo. And that's usually what we'll do is one and the other. And then what they'll do is they'll do the surgery. Now, one of the things about the brain, it's very particular about fluid. It doesn't want too much. Because if you overload a brain with fluid, like let's say you gave too much IV fluids, it's going to swell the brain. And the brain doesn't like that. So we got to be very careful. Another thing, if we had this tumor and the doctor removed it, there's an empty cavity there. How do you position that patient, that child, after surgery? Does he lay on it or off of it? How elevated is the head of the bed? Very important to look for those positionings, right? Because we need to make sure we're not doing anything to harm that child. And of course, you're doing all the neuroscience and vitals and all that, but it's that positioning, fluid management, and always pain control. I'll always say that. Probably the one thing that we don't do a lot in children, and it was always my pet peeve. Make sure you take care of these kids. Now, neuroblastoma. Well, you think neuro, you think head. This is something that starts in the abdomen, and it gets bigger and it crosses the midline. And by the time you see symptoms in the head, that's already the metastasis of it. Not a good outcome. Very rare, but we do mention it. Again, this is a child who probably is not going to make it. We try to take out the tumors. We try to catch it early, but if it's already, in the brain or swelling, outcomes aren't good. Now, osteosarcomas, bone tumors. Well, how do we know this one? I was just watching watch TV movies. It was about a football player who walked on the field, and I think it was a Notre Dame was the was one of those prestigious schools, and he got on the team finally. And he did good. He did so well. He got on the team, and all of a sudden he started pain in his knee and limping and limping. And it ended up in the end, he had a osteosarcoma of the femur bone. Usually it's long bones, but that's the most common that I've seen it as. And usually in children, the younger kids, you see it with a limp. Limp on a kid, there's something going on. And then, of course, you're going to look. If it's a cancer, you're going to see anemia and weight loss and infections. X-ray, you might see a little fuzz. CAT scan, MRI, you'll see a little bit more, but they'll do a biopsy and see what the cancer is. Now, this is a femur bone. You can't keep any of that bone in there. That cancer is in that whole bone from the hip to the knee. So what do you think we got to do? Well, there's used to be everyone got an amputation. Where are you going to put a prosthesis to walk around? There's nothing to hook it on, right? So today we're salvaging the lower part of that leg, inserting it backwards up into the hip. And what that allows is for a prosthesis to be able to be positioned so that child, and they're usually adolescent males. That's how, remember the mind of body image, identity is a hard cancer to work with for the parent, the child, the nurse, everyone. So you'll do the chemo, we'll do the surgery, we'll turn it around, and then it's going to be intensive physical therapy. And hopefully we'll do the salvage the limb. That is our goal. But sometimes we do have to take it, the whole thing, do the amputation, but we don't want to. Wilms tumor. Let me tell you a story about a Wilms tumor. I've seen one. 3-year-old boy came over after the Haitian earthquake. And he was brought into the ER trauma, the triage room where I was doing triage. I love doing triage. And brought him in. And I said, "So why is he here?" "I don't know. They told us to pick him up at the airport and bring him in." So I did. And they did, and they brought him to me. And they had records. They're all in French. I don't speak French. So now I've got to do an assessment. My job as a triage nurse is, where do I put this kid? So I went, and number one, I gave him a sticker. Now, I speak parlez-vous français? Je parle un petit peu. I mean, just trying to be silly with this kid, and he smiled. Okay, so I broke the ice. Of course, I sat way below him, gave him a sticker, and then I took the temperature, put underneath my arm, put it underneath his arm, and we did a set of vital signs. And then I listened to his chest, and then I listened to his abdomen, and in the left lower quadrant, I felt a soft ball size hard tumor. And I have no clue why I knew, but I knew it was a Wilms tumor. The thing about Wilms tumor, it is a tumor that comes off the kidney. You really don't feel it as in pain on these children. It's usually that assessment that you see it, then they go ahead and they'll do some sort of x-ray, of course, CBC, to see where the cancer is, because it is cancer, and see where we're going with it. So one thing about that tumor is you can touch it, and it's so fragile, pieces will break off into the peritoneal cavity. You cannot palpate it. You will not do a biopsy on it, because that biopsy will put a hole and let the cancer go into the whole abdominal cavity. Amazing, huh? So you, even changing a diaper on this child, you got to be careful not to manipulate that tumor there. So they'll do surgery on these children. They have to go through the front all the way to the back and get that kidney out. And these kids actually do really well. They do really well postoperatively. Again, as I said, you always have to be careful of that tumor. But postoperatively, you've gone down deep into that abdominal cavity. You worry about a paralytic ileus because of the manipulation of that intestines. And of course, you've messed with a kidney. You got to look for urine output. But that little boy went back to Haiti. He was cured. And the unit where they took care of him postoperatively did get a card from him. A month or two later, somebody who knew English had sent it to him, knowing that the kid was doing well. And that just makes my heart sing that I figured it out first. So that's why I like triage. Rhabdomyosarcoma, these are soft tissue tumors. They can go in the eye, the nose, the gums, the ears. Again, these are things that's going to have to be removed. Retinoblastoma, it's in the retina. And these kids, you flash a light and you're going to see that little white thing. Like they used to years ago, they took a picture with those big cube type of flashes and everybody's eyes were white back then. Think about going to your backyard and it's dark out and you see an animal in the back, you see those shiny eyes. That's what that is. It's called a cat's eye, too. It's one of the names for it. But this, we worry about that, again, metastasizing. Soon as we see these things, it's a radiation. Let's shrink that thing. Sometimes we can do it with the radiation, get rid of it. Many times you have to go beyond that and you have to take the whole eye out. And if it's contained, we get the eye out. This kid will get a prosthesis eye. I mean, I had a kid in high school who used to take his eye out and roll it around the desk. I had no clue what that was as a high school kid. I wasn't a nurse yet, right? Looking back, I think he was a retinoblastoma. Why else would you have a fake eye in you, right? And he used to do that just to weird out all the girls. That's high school, right? Anyway, with all of this stuff, make sure the kid and the parents know what's going on. It's difficult for a baby to lose an eye. And the one I've seen was a 10-month-old girl. I didn't see the end of it, but I saw the beginning of it. I'm like, oh, that's retinoblastoma. Germ cell tumors, another story. This is a scrotal tumor, testicular sac tumor. This is why men with testicular pain If they're having pain that's that annoying, they need to go get medical treatment. It's like women checking their breasts monthly, men should be checking their testicles. And if there's any lumps, they need to check it. Had an 18-year-old boy come in to triage, and I was in the room with another nurse, and I heard her say, "Don't pull you down your pants," and she put gloves on and she felt the testicles. Well, one testicle was huge and the other one not, and it was painful. The end of the story. They took that kid to the x-ray department and did an x-ray of his abdomen and chest, and he had metastasized all the way up and down, and that kid died within 3 months. So testicular pain, pay attention to it, and that's a germ cell tumor. Liver tumors. Well, we have got a lot of lobes of liver, right? And they regrow. Sometimes we could just take out that piece and we'll be fine. Sometimes we take all of it out and put another one in. But liver transplants can be done. Again, liver tumors, you got to take it out. So cancer survival. When we talk about cancer, this is actually older information. Survival rate 80. I'm sure it's even more now because of all the treatments and what we're doing right now. I know that, cancer used to be, oh my God, that's it, you're going to die. Today, with all of the treatments, all the new chemotherapies, they're doing a lot better. And, the Facebook, when they see these little things there, cancer free, I always read the stories. I want to know what's going on because that kid has fought like heck in order to be cancer free. So that is my lecture for tonight. Anything you need to know. So we have a choice here. I know there's about 6 of you that need some dosage calc. I can do that right now for everybody. Or I have a 50 question Cahoots, which is going to run late. What do you want to do?
Dosages, please.
Dosages, please.
All right. That's not a problem. I'm here to help you. All right. Let me get up a worksheet. I actually put together a little bit of a different one. I call it Review B. Had some new questions on it. And let me go over that. All right. Now, these first 5 questions, very similar to what's on the exams. So that's why I put them here. They're not the same numbers, the same meds. It's just the same type of distractions and things in here that you are going to see on any of the 5 questions in your exams. On this one, we have 2 different formulas we're going to use. Now, there are only 3 formulas that I use for dosage calc. There's one on a dose to be delivered. And the dose could be, the amoxicillin, augmentin, whatever, or it could be mics per kilo per minute. That's a dose, isn't it? The doctor ordered 5 mics per kilo per minute. It's a dose. I can show you how to do that one, and I will because most of you are in med-surg too. And then the second one that's used, because we don't have any drops per minute in any of our exams. So I gave you a hint there. So the second formula is mLs per hour. And that measures volume delivered and time in minutes. Doesn't matter what you're given, it's volume and time. So what do we do first? Now, first thing you do when you start an exam is write those 2 formulas down. One is DH times Q over 1. And always put 1 so that you keep it straight, so you don't get crooked when you're trying to multiply and divide, okay? And then the second one you're going to put down is volume in mLs over time in minutes times 60 over 1. I will tell you that times 60 is forgotten a lot. So that's one thing you need to make sure. All right. First question. When you say prescribed, order, need to deliver, these are a dose that needs to be delivered. So, question number 1 here. We have a dose that needs to be delivered. Prescribed, whatever the name of the medicine, I don't care because we're looking at doses, not names. So it's prescribed 100 milligrams to be given. And the nurse has available, so you have 60 milligrams, and it's in 2 mLs. Now, let me go here. So we have 100 milligrams. This is my D. Now, I use DHQ, you could DAQ, whatever you want to call it, but it's a dose to be delivered, what you have available or on hand, and the quantity that stuff comes in. And I always put it out and I fill it in. I do never change anything from the question. Whether it's, it says 1 liter, I'm not going to change that to 1,000 milliliters. I put everything down first the way the question asks. Over 60 milligrams, right? And it came in 2 mLs over 1. Now, the next thing I'm going to tell you is multiply first and then divide. Do not divide and then multiply. And the reason is many times you're going to end up having to round if you divide first and then multiply. And you want to do the least amount of manipulation with this so that you make the least amount of mistakes. That's why I don't like a ratio proportion analysis or whatever it is, because you're adding, subtracting, crossing off. I don't get it. But this way is so simple. So if we multiply 100 times 2, we get 200. Another thing, look, milligrams over milligrams crosses itself out. My answer is mLs. And that's important when you get to milligrams per kilogram, because you're going to say, well, how can it be mLs? That is that ml per hour formula. No, it's not. It's a dose to be delivered, right? So milligrams crosses out, mLs is going to be my answer. So 100 times 2 is 200. I'm going to divide by 60. And I get 3.33. The next thing that you will do wrong is you think you know the answer. Don't think you know the answer. Go back to the question. Does the question want a whole number? Does it want to the 10th? Does it want it to the 100th? Make sure you're answering it. Because if you have the right answer, but it's not given to me in the format I want, it will be wrong. Okay? Very common error. So let's see what it says. Round it to the nearest 10th. So our answer would be 33.3. How's that? Let's do number 3. Somebody talking?
I said 33.3.
Yes, ma'am. No, wait. Let me do it again.
3.3.
3.33. I did these so quick. This is an extra one that I did. 100 is our dose times 2 equals divided by 60. $3.3. I just did this the other day when I was doing some dosage calc with somebody, and I was trying to get in some quick different numbers for them. All right, we know number 2. Now, I told you never change anything. Put the information from the problem on to your paper first and then change it. So, orders, delivers, prescribed. A dose is given here. And what is my dose?
1 gram.
It's 1 gram. And what did they send up to me to use? 250 milligrams. And it's in 5 mLs. So let's do that one. And again, write it down the way you take it from the problem. And then you go back to the paper and make sure that is the numbers that was given to you, okay? Always double check. And as I'm doing stuff with calculators, I've got these sausage fingers and nails and hit the wrong things. So do it twice. Always do your multiplications and your divisions twice. If you do it that way, you'll always be right. So we know it has to be volume in milligrams, right? Milligrams and milligrams, because you can't have apples and oranges. It don't work. You have to have the same labels. So to go from grams, to go to milligrams, to go to micrograms, you have to go to the right. You go from one big one to a million of them, so you have to multiply to get more. Then you go to micromillo, even more of them. So more means you multiply. And that's how I remember grams, milligrams, micrograms. So 1,000 milligrams over 250 milligrams. And we know milligrams get crossed off, so we know our answer is going to be mLs. So we put 5,000, multiply the top first, divide it by 250.
Good.
And what'd you get, 20?
Yes.
And that's how it's done. Does that make those sort of questions easier for you? Again, you try to change up 2 things too much, you can erase and redo it. You've got paper, you've got your whiteboards, use up your things. Don't think you have to squeeze something in there. If you always put your formula right off what they're asking for, you're not going to make errors, because those are where the errors occur. All right, let's do number 3. Number 3 is, we have a child who weighs 40 pounds and is ordered, that's a DHQ question, and is prescribed medicine 0.15 micrograms per kilogram IV. All we're looking for is a dose here. So we just need to figure out micrograms per kilogram. So let's go. So the kid weighs 40 pounds, right? Is that what I said?
Yes.
Yes.
Okay. And we have 0.15 micrograms per kilogram. Well, we need kilograms. We have pounds. Now, another thing, sometimes without practice, some students will put the pounds as in a smaller number and kilograms in larger. Let me tell you how to remember it. I weigh 100 kilograms. I don't weigh 201 pounds because I don't like a big number. So kilograms is always a smaller number. So I need to divide 40 by 2.2. Now, whatever you get on your calculator, leave it there. I got 18.181818. Every single kilogram gets that much. All I'm going to do is multiply it by that number now, times 0.15. And I get
0.72.
now, what is my answer? I don't know yet. I've got to go back and I've got to find out, what am I looking for? And they're looking for the nearest tenth. So it'd be 2.7. All right, heparin, insulin, any of those. Do units bother any of you, the label? Does it make you like crazy? Like there must be something different because it's units. Some students,
I always had a problem because it did confuse me because I
all right,
always
make it
tried to add it
milligrams.
in.
Make it milligrams. Because the label is going to be crossed off anyway. So if units bother you, take it off, because all it's asking for you is mLs per hour. And we know whatever dose over what we have, we're going to cross off the label. So it's going to be gone anyway. If you don't want to use it, just forget there's units there. Okay?
Can you explain that again?
2,500 units. Excuse me?
Can you explain that again?
If the label units gets you confused, don't use it. You can make that in a dose of heparin or insulin. I say, well, use milligrams. Does it matter if it's milligrams or units? Because I'm going to end up crossing them off anyway. And I'm going to show you when we get there. So what do I have on hand here? I'm going to give a dose. It's prescribed 2,500 units of heparin. What do I have?
$25,000.
I have 25,000 and it's in a 250 ml bag. Let me show you what I'm talking about. 2,500. Does it matter? Well, we'll make it X's. It doesn't matter. And then that is over 25,000 X's. Units, milligrams, micrograms, whatever you want to call it. And 250 mLs. Remember, this over this gets crossed out. So it's gone. So you really don't even need it there in figuring out a problem, okay? We know that medicine comes in that, but all we want to know is the quantity that we have to use. So heparin and insulin are all a DHQ question. Again, multiply the top, divide the bottom. So 2,500 times 250.
625,000.
And we're going to divide that by 25,000. We know our only label left is milliliters. So let's just divide.
25.
And our answer is 25. Now, does that make that part easier for you?
Yes.
That's the way. Don't overthink it. We have a dose, deliver it. Or we have volume in mLs or volume in time. Always take and have those formulas written out. Like when I say go for the exam, write it on your whiteboard, your piece of paper, and you have it there. So as you're going through the exam and all of a sudden you get a math question, you don't have to stop. Now, I told you I would mention some of the mics per kilo per minute, because I know that in your med surge too, you have these things. So let me pull one of those up for you. All right, I'm going to go right to one of the harder ones. How does that sound? Let's go to number 2. Remember, when you're giving a mics per kilo per minute, you're giving a dose of something, okay? So in number 2, my dose order is this medicine. It comes in 500 mLs. That's what I have. The dose I want to give is 2 micrograms per kilogram per minute. And the dose came in 250 mLs. This patient weighed 125 pounds. Let me show you how easy this one is. It's just like all the other ones I've done. 125 pounds. We have to change that. But our dose, 2 micrograms per kilogram per minute over, it came in 500 milligrams, and it was in a 250 ml bag. We've set it up right from the problem, right there. The first thing I need to do is change pounds to kilograms. So 125 divided by 2.2, 56.8. We're going to take it there. Now, when you look at the question, they want to know mLs per hour. We have minutes here. If it had 2 mics per kilo per hour, you do nothing. But because the answer wants hours, you have minutes, you'd have to multiply that by 60. Are you following me? The other thing is we do a conversion. There's micrograms and milligrams. And I always leave the dose the way it is, and I'll convert the other one to it. So milligrams to micrograms, it goes to the right, right? I showed you earlier. We're going to multiply that by 1,000, and it is 500,000 micrograms. Now let me show you something. Micrograms over micrograms is going to cross off. So it's going to be mLs per hour that is left. So let's just multiply again the top line and then divide it by the bottom line. So 2 times 56.8 times 60 times 250 equals, and don't be afraid of these big numbers, okay? And we'll divide it by what we have. 500,000. And our answer is 3.408. Again, this one doesn't have it, but our answer would be 3.4. It doesn't ask to go to the 10th or whatever. Now, did that make a mics per kilo per minute question easier for you? Or are you still lost?
Professor, when you multiply the top part, you multiply by 56.8 or you round it?
No, leave it right there. Absolutely, leave it as big as you can. I usually will just leave the 56.8 and and multiply it times 2 times 60 times 250. It's not going to do you wrong to leave it there. Because if you're rounding it, Navy, aren't you going to maybe make a mistake? Possibilities are always there. So what you have, just use it. Don't try to round. Don't try to change until you have it there. And it will decrease your errors there. Okay? All right. I'm going to stop because you guys are brain dead. I'm a little brain dead with you. I hope that helped. Anybody who wants any other further, I'll show you how to do it. There's also many other tricks within it. And if you have some questions that you might have seen in the Med-Surg 2 exam, let me know, because I don't have access. So if you can tell me, are you doing mics per kilo, milligrams per kilo? What are you doing so I can make sure that you know them? I'm going to help you in Med-Surg 2 also. All right? And that's all I got for today, guys. I'll be sending you the Kahoots. Make sure you watch it. I spend a lot of time on the PowerPoints and the Kahoots to make sure everything you need for exams and HESI is there. So I review them every quarter, every time I do a new class. So make sure you do go through and do those Kahoots. Play with each other. I mean, you can do that. So, I mean, have fun with them and try to beat each other, okay? And in any questions, just let me know. Not, I'm going to see you all next week. Come do a review. All right. I'll be around and I'll be posting for you. So thank you guys. And Osanda, I'll still see you 2 o'clock if you want.
Okay.
Not a
Okay.
problem. Okay.
Yes. Okay.
And anybody else who wants to see me, no problem.